Good afternoon, everyone. Thank you for joining this webinar on applying testing recommendation in community setting, which is organized by the European AIDS Treatment Group Diagnostics Initiative and the European Testing Week. So the reason EATG is organizing this webinar is to provide support for learning and exchange on effective testing approaches by lay providers between community service providers and interested partners. So in this webinar, we will examine tools to support integrated HIV viral hepatitis testing as per ECDC testing recommendation, with a focus on community settings. The webinar also takes part in the context of the European Testing Week as a preparation for upcoming activities, and this is why they endorsed the initiative endorsed this webinar. We have asked Miguel Rocha, who is working at the Checkpoint Lisbon and GAT, and also who has been supporting training of community healthcare workers to present the tools that they have used to help the person performing the test to select in an effective and quick manner which test to use in the context of the integrated testing recommendation. And he will also present on a tool that Checkpoints and the network of community centers are using to select which test to use. So on that note, yes, and before we start with the presentation, we will take questions for clarification after the presentation, and then we will open up for comments and further intervention, as we would also like to hear from those of you involved in interventions, which tools you are using, or maybe you have comments on what has been presented. The audience of this webinar is composed of, as per the registered participants, companies producing diagnostic tools, solutions, community or people working in community centers, and we hope to have some of the agencies involved in the recommendation setting taking part. So on that note, I pass the floor to Miguel Rocha.
Thank you very much. Welcome everyone. Good afternoon. Thank you first for the invitation, and thank you all people attending. So as it was said, I will be very welcome with inputs and suggestions to improve our work, and questions are very welcome. So my name is Miguel. I work at GATS. I'm a nurse in charge in the Checkpoint Lisbon. So my work was always as a community health worker role to provide integrated testing to men who have sex with men. And I was also responsible to do the trainings in this center. And with this experience and knowledge in another project, I was involved also in the training of community health workers in a national screening community network. So just a quick overview of GATS. So GATS have several services and initiatives and targeted services.
Miguel, sorry to interrupt you, but we can't see your screen, your presentation.
Okay, let me check, go back, yeah. And now?
Yes.
Can you see? Yes? Okay.
Yes.
So let me go back. So this was the first slides, and then I was presenting GATS, a quick overview of GATS and their services. So there are several transversal services, initiatives, and targeted services. So I work in Checkpoint, and in another transversal services, the community screening network. So GAT is an NGO that aims to provide access to prevention, harm reduction, early diagnosis and treatment services to tackle HIV, STI, hepatitis, and tuberculosis endemic. by enhancing local community participation in service delivery, decision making, and research. And this presentation is within the scope of the Portuguese Community Screening Network. The Portuguese Community Screening Network is a network of NGOs that are targeted to at least one priority group, where the HIV, HPV, HCV, and syphilis epidemics are concentrated. They are located in urban and coastal areas of the country, where the epidemics are concentrated, and they act as an information, testing, and linkage to the National Health Service sites for these for infections. And they also collect information during the testing session to enable second-generation epidemiological surveillance. So as they provide the testing, they collect several indicators that are used as a cohort study to estimate incidence and predictors for seroconversion. So as you can see, all the NGOs, the part of this community screening network, are located in cities, urban, coastal areas where the epidemics are concentrated in Portugal. The Portuguese Community Screening Network is promoted by GATS. We have the main roles of training the community health workers to provide integrated testing, to help them to collect data during the testing sessions to feed these cohorts, so the second generation epidemiological surveillance system, and to support member organizations to enroll and take part of the external quality assessment programs, and to select and distribute rapid diagnostic testing to the NGOs. We also, in this joint network, is also promoted by ISPUP. ISPUP is the Institute of Public Health of University of Porto. They have the main goal to train the community health workers to collect this surveillance data in the testing session, to manage this second generation epidemiological surveillance system, to report activity indicators to the NGOs, so they can have their data treated automatically, and to support this organization in the analysis and publication of the data of their activity and the granular surveillance. And we also, by contract, a laboratory, national lab, to provide externally quality assessment of the rapid diagnostic tests and to provide lab supervision of these testing sites. So in the context of this presentation, we will do first go to a triage guide tool, and then the test selection methods of the rapid diagnostic tests. So the Triage Guide tool, its origin. So this network offers integrated testing, and in all NGOs they have community health workers, and most of them do not have a medical background, so lay providers or social or psychological backgrounds. So because of that, they are not trained to think like in a triage algorithm with medical criteria. The rapid tests are targeted to those who meet at least one selection criteria, and the selection criteria are based in the most current knowledge of the transmission routes for these infections or practices of potential exposure. So as an example, I will show the criteria for the 4 infections. These criteria as a reference from the WHO, CDC, European CDC, so the international recommendations and national recommendations for testing. So as you can see, as a criteria to target HIV testing is people without a previous diagnosis and do not always use condoms in vaginal or anal sex, or are doing PrEP or are seeking for PrEP, having sex with people living with HIV with detectable viral loads and are not on treatments, had or have shed injecting drug use materials, or have a reactive rapid test diagnosis or a diagnosis for another STI, tuberculosis, or AIDS defining illness. For HPV testing, as you can see, we have a lot more of criteria. First, people need to not have a previous diagnosis for HPV infection, and people who report less than 3 doses of hepatitis B vaccine should also be tested. Or if there is no written evidence of these 3 doses and people do not know, and they are born in Portugal before 1991, They also should be offered testing, or a pregnant woman, or injecting drugs, or have sexual partners with active hepatitis B infection, are housework or caregivers or professional health professionals for people with active HPV infection, are in long-term hemodialysis, traveling to countries with moderate HPV rates, had undergone surgery or blood transfusions in countries with moderate high prevalence, or born or originating from these countries, like migrants, refugees, asylum seekers, and adopted children. The criteria to target for hepatitis C testing are even bigger, so more. So people without a previous diagnosis for HIV infection and who share material, had group sex without using a condom or without exchanging the condom when exchanging the partners. The same applies for feasting or sexual toys, sharing the jar of lube during group practices, having piercings or tattoos at home, street, prison, or army, having manicures or pedicures where the material was shared, had a male sexual partner with active hepatitis C infection, long-term hemodialysis, exposed to blood with blood contact at work, or have a blood or organ transfusion before 1992, or coming from these countries with high hepatitis C rates. As for criteria to target syphilis testing, is way more simple. People without a previous diagnosis of syphilis infection and had oral, vaginal, or anal sex without using a condom. So, as we could see during the trainings, the community health workers are informed of these criteria to target the rapid diagnostic tests. And it was reasonable to see that during this training, the most common questions is how can I apply them? It seems to be this asking all these questions, it will be quite invasive and hard to do. How can I remember all of these criteria during a pre-testing to choose the tests to apply? It seems to be easier to apply the 4 tests than ask all of these questions. So as during the trainings we are getting this feedback, we start to think how can we operate these criteria like in a triage guide tool to help them apply them effectively and quickly to decide which tests to apply in a specific testing session. So the triage guide tool was built to facilitate the testing selection among community health workers and lay providers, and to decrease the use of tests not indicated or increase the use of tests indicated and reduce pre-test time. So to apply the selection criteria as we see before, fast and effective manner. So this is a translated triage guide tool that we use in the testing sessions. So we start to ask the sexual identity of the person with the division of sex assigned at birth, the gender identity, and with whom they have sex with. So this is a way to overcome or to find out trans people that sometimes they are not self-identify themselves, and people, because of asking only sex, they say the gender and not the sex assigned at birth. So with this sexual identity be asked like this, we can right up front to see what sexual practices may be or not be involved, and have the testing session counselor to do specific counseling regarding those practices. Then we ask how old are people. If they are under 12 years of age, they should not proceed to test. If they are over 12 years of age, they can proceed to test. It's people between 12 and 18 years old. It's a superior interest of the child to know their status for this sexually transmitted infection, so we provide testing as an ethics committee approval. Then we ask what country they are born in. This will be very helpful because of endemic countries for hepatitis B and hepatitis C infections. Then regarding HIV, this was the easiest one to people to identify if they are entitled to do the testing or not. So only one question is asked: have you ever been diagnosed with HIV? If they say yes, then we go to the question P5 that is below in the form. And P5 say, are you looking for access to confirmation and treatment of the infection? If they say yes, then we ask, did you bring the proof of infection with your name? If they say yes, we do not test. If they say no, we test to confirm their status to make a referral to the national health system. In the question P1, if they say no or I don't know, they are entitled to testing. Community health workers find it easy to ask questions about the condom use or PrEP use to decide if it makes apply to the HIV testing or not. Since we are targeting priority groups, they are all entitled to do HIV testing. So if they do not have a previous diagnosis of HIV, that's enough to decide to apply them. Regarding syphilis, also as a routine test for the priority groups, if they are never been diagnosed with a syphilis infection before, they are entitled to do the testing. If they say yes, then we link them to an STI appointment. Regarding hepatitis B infection, the first question that we do ask is, have you ever been diagnosed with hepatitis B? If they say yes, it's the same question P5 as for HIV previous diagnosis to decide linkage to care and if we apply or not the test if the person do not bring a proof of the infection with their name. If they say no or I don't know if I ever been diagnosed with hepatitis B, then we go and proceed to question P3.1 and we ask about vaccination. Do you have 3 doses of hepatitis B vaccine? If yes, there's no need to test. If not yet, because they are starting doing the vaccines but not yet completed, we ask, have you had a dose of hepatitis vaccine in the last 2 weeks? If they say yes, or I don't know, we should delay the testing at least for 2 weeks, or else the test will be positive because of the vaccine. If they say no, then we proceed to testing. In a question 3.1, if they say no or I don't know if I have the 3 doses for hepatitis B vaccine, we go to question 3.3 if they were born in Portugal, or to question 3.4 if they are born in another country. If they are born in Portugal, we are asking in which year they were born, because people that were born after 1990, it's more likely for them to be vaccinated because the hepatitis B was introduced for the national vaccination program for all children as an universally care. If they are born previous than 1990, they should be offered testing. It's somewhat likely that they are not vaccinated against it. The National Health Service has also an app that can allow people to download their vaccines registry, and we sometimes help them if they are unsure of their vaccination status to download the app, and we can see if they have 3 shots of the vaccines or not. So if a person is born in another country, not in Portugal, we should look if this endemic for hepatitis B. And in question 3.5, we have the endemic countries. In Portugal, they are organized from A to Z, but as I do the translation in Google Translator, this is not anymore from A to Z. So the community health workers just have to look from A to Z if the country is there. If it is, it's a higher priority for testing. If it's not there, it's a low priority for testing. What does this mean? This means if we have a good stock for testing, we should test either way, irrespectively of it's an endemic country or not. If we have a shortage of rapid testing, we should prioritize access to screening for those coming from endemic countries. Going for hepatitis C infection, the first question is, have you ever been diagnosed with hepatitis C? If yes is the same question as for HIV and hepatitis B regarding linkage to care. If it's no, we go to the question, have you ever been tested for hepatitis C? If yes or I don't know, we go to the question 4.4 that asks for all the situations that happen in your life or since the last test. If they say are never tested, then we go see if they was born in an endemic country. Because if they were born in an endemic country, we should test, and there's not necessary to ask the other questions below. If they say no, because it's not born in an endemic country, then we ask the questions below. The questions regarding hepatitis C were found by the community health workers very intrusive and invasive because there were sometimes stigmatized practices, commercial sex work, group sex, drug use. So as a strategy, we decide to present the list for people to read, or the community health work read all the situations that can lead to hepatitis C transmission. And at the end of the list, the person going for testing just have to say yes if at least one happened, or no if none of these happened. So it's a self-qualifying question to overcome these perceived barriers from the community health workers to ask these questions, and from the persons going for testing to disclaim one by one these practices. So this was the Triage guide tool. As you can see, it's only one paper with 15 questions, and this is applied with training. After training, and people take 2 to 3 minutes to ask these all questions. And after this is filled, they know which of the 4 tests to apply and the reason why. As the second part of this presentation, since the GAT has also the responsibility in this network to select and distribute the rapid diagnostic testing, and we are in the process of deciding which tests to use by 2020, we will show the method that we use to make an assessment of the rapid diagnostic tests available in the Portuguese market, and how we compare them and which ones we decide to use in the next year. By August of 2019, the RDTs available in Portuguese market are the ones listed in the table. So when you see A, it means they do not have CE marked, so we cannot use them. If you see B, it means that it's not available in their catalog. So some manufacturers have for HIV and not for viral hepatitis. Others have for HIV and viral hepatitis and not syphilis. So this is presented here. When you see the letter C, it means that the rapid test does not allow the use of whole blood. It means only plasma and serum. So we cannot use them as a community health workers using finger prick. And D means that the instructions of use or leaflets were not sent to the manufacturer for assessment. So they were excluded of these assessments. We apply the Assure method. It's an adaptation of the Assure method that is presented for RDT comparison by the WHO. The criteria are the ones presented in the column of the left. So affordable, sensitive, specific, user-friendly, robust and rapid, and equipment-free and deliverable to those who need them. But in this Assure method, they do not have specific sub-criteria for us to do a comparison. So we look into the different criteria and what it means for a community health worker or a lay provider to be a user-friendly testing, and we transform that in a criteria. What it means to us, robust and rapid, and we transform that in a criteria. So as you can see, we have in affordable, we have 2 criteria. So the first criteria is having the lowest price per test. So we ask the price for each box of testing, and we divide per tests there. If the tests to be used, they need extra material, like a buffer because it's not included, or a capillary because it's not included, this is also taken in consideration to make the calculation for A1. So we only consider the price per test with all the material that is needed to perform the tests, because sometimes the manufacturers sell the tests without the capillary and the buffer. So we take that in consideration while doing the comparison. From A2, the lowest shipping cost per test. So if we have to ask for a box of tests to come to GATT, sometimes the amount make a difference in the shipping costs. So we ask for a shipping cost for one box, so the highest price possible or expected. As for sensitive, is the sensitivity reported by the manufacturer for all blood sample for fingerprint. For specificity, we go to instructions of use also of the tests and search for the specificity reported by the manufacturer for all blood sample or fingerprint. Sorry. For user-friendly, we have 8 criteria. The first one is having the few steps as possible, and we count that after the digital puncture. So as fewer steps, easier to use. The second criteria is the smallest possible whole blood sample. So in the integrated testing, we could do up to 4 tests. So the smallest possible whole blood sample is an important thing, because for 4 tests means a lot of blood. So we prioritize tests that use less whole blood. For criteria 3, to use a capillary or loop instead of a pipette. Community health workers find the use of pipettes very hard to use, so capillaries are very easy to use, and the loop, as for an example of a loop is the oral advanced hepatitis C tests, so it's like a loop. It's easier for the community health workers to use, so these ones were prioritized than the pipettes. For criteria number 4 is if allows ETTR capillary. We have sexual transmitted infections appointment, and sometimes we have whole blood collection for other testing, and we need to have rapid diagnostic tests that allows the anticoagulate FDTA for that use. For the criteria 5, if the whole blood specimen for fingerprint is allowed in the instructions of use. For the 6th criteria, to use a few drops of buffer as possible, because it makes the simplification of the testing procedure also. Number 7, the sample window is the same window as for the buffer. If we have different windows for a sample and a buffer, sometimes that goes to invalid testing. So sample window being the same, simplify the use, so it's more user-friendly. The 8th criteria is that the instructions are in Portuguese, so no translation from other languages. As reverse for rapid, we have 5 criteria, having the longest results reading interval, because we do counseling, we do investigations, and if the test result needs to be communicated in the, for instance, the INSTI-HIV, we do the test and we can read the result after 1 minute up to 5 minutes. And another test, most commonly, is after 15 minutes, and we have up to 30 minutes. So we have a window, a bigger window to talk with people while waiting for the results. For second criteria, the highest temperature range for conservation. This is mainly because of mobile units. So the biggest higher range of temperature, the better the test to use in mobile units. For R3, internal humidity control, if they have it or not. Number 4, internal quality control, if they have it or not. Number 5, the shelf life more than 6 months guaranteed by the manufacturer. And E1, no sample processing required, or D1, no cross-reactivity between these 4 infections. This is one thing very important, that we do not want cross-reactivity between these 4 infections because we are doing integrated testing. So this is quite important. And sometimes the manufacturers do not present this information in their leaflet, and it's quite common for syphilis tests to not do or not present this information, not that often for HIV, because they do this and present this information for viral hepatitis and syphilis, but not the other way around. How do we score this sub-criteria? So in the first criteria, we divide unit price by the number of tests contained, considering all equipment necessary to do the testing. And then we order from A to Z. So if we are comparing 10 tests, the first one in the ranking leads to 10 points, the second one 9 points, so forth and so on. If they have a match by scoring, imagine 100% of sensitivity, they all get 10 points, and the second one 9 points, and then on. For A2, the shipping cost of 1 unit, so the lowest order possible, and we order from A to Z. And if we are comparing 10 tests, as I was saying, the first one gets 10 points, and the other one, second one, 9 points, and so forth. For the sensitivity percentage reported for all bloods, and then we order them from Z to A, so the biggest sensitivity to the lowest, and we score. Specificity the same, the Z to A, and then we score the biggest one with 10 points. For the number of steps after finger prick, we order from A to Z, so we do score better those who have lower steps. Sorry, hello?
Miguel, sorry, it's just because we would also like to leave some time afterwards for the
questions. Oh,
yeah,
okay.
so.
I'll be going faster.
Sorry, don't mean to press you, but yeah.
Okay, thank you.
Yeah.
Okay, so for the whole blood, we rank for the lowest blood to the highest bloods. For the pipettes, we rank better those who use capillary and loop, and less the pipettes, and 0 points for none. 0 points if not ETA allowed, and 1 point if it's ETA allowed. 0 points if no reference to fingerprint, 1 point if yes. 0 points if no common window, 1 point for yes. 0 points if no instructions in Portuguese, 1 point for yes. And regarding the time of intervals, we make a subtraction and it will rank. The storage temperature is the same. Sorry. R2 is regarding the humidity control. If there's no second, 0 points. If there is yes, 1 point. If the second also changed color when moist, 2 points. Regarding the internal control, 0 points if there's no internal control, 1 point if yes. Regarding the shelf life, 0 points if no for 6 months, 1 point for yes. And regarding equipment free, 0 points if no equipment free, 1 point for yes. Regarding the no cross reactivity, 0 points if any cross reactivity reported or the information is not provided, or 1 point if no cross reactivity for the other 3 infections. So now we are going to see examples for the 4 infections. So since I didn't have the price for all the manufacturers, I removed this information from the ones I had. So we only are seeing the criteria applied from the other one, the other criteria. So this is the score given, and this is the final score. Since we are comparing 10 tests, we go from 10 to 9 applying this method. So as you can see, the 4 tests more with better score are those in bold. Of course, the prices per test and prices per shipping will change this ranking afterwards. Okay. This is another example. This time is for hepatitis B infection. So this is the criteria applied. This is the score given. So as you can see, only 3 tests. So the score starts with 3 and goes to up to 1. This is for hepatitis C. This is the criteria applied, and this is the score given. So 6 tests. So the first one starts at 6. And the last one is for syphilis, the criteria, the score given. One thing that is important regarding this method, at another choices will taken into favor for integrated testing to be easier. So we will take also in consideration then when choosing the 4 tests, we will choose the ones who have equal number of blood drops and equal number of buffer drops and equal time for results. So to make easier that all tests run in the same way. So this is also taking into consideration at the end of the selection method. And that was it. Thank you for your attention.
That was a very comprehensive, and maybe we can make one of your version of your slides accessible for interested persons, so they can look into more
detail,
like to go through the criteria more thoroughly. I wanted to ask now if anyone has clarifying questions or comment to Miguel on the 2 presentations. Okay. So I see there are some, from what I can see, there are some participants that are taking part in community testing at local level. Does this tool resemble what you're using at local level? Or do you have different methods? This is always the tricky part with webinars. Is
the exchanging part, yeah.
The exchanging part. But Miguel, do you have questions to participants that you know, burning question that you always had and never or didn't get to ask, or
I was also interested to know if they have the similar guide tools when they do the pre-tests, how they quickly decide which tests to apply, or if they have a different approach. And also how do they select their tests for their work, if they have the same criteria, if they take into account different criteria than we take. So I would be interested to know that.
So there is one question. Could you give an estimate of the percentage of those screened? Sorry. Oh, sorry. The response doesn't show well. So could you give an estimate of the percentage of those screened, or maybe actually, because I can't read it, something doesn't work. You can unmute yourself. It's Pedro Domin.
I have another presentation from the Community Health Screening Network with the data of the tested reactivity rates. I believe is that the question, correct? Hello?
Yes.
Yes, yeah. So I will find the presentation quickly and show that slides.
Miguel, there was another question for afterwards, which was how has governmental institutions reacted to your method? Are they supportive, or was there any feedback?
Regarding the triage tool, or regarding the method applied to select rapid diagnostic tests?
Apostolos, do you want to come in? Because you were asking the question both. So,
to both.
Yes.
Regarding the criteria that we used, the national guidelines are taken into account, so we are in compliance with them. So we never received a bad remark regarding them on the use of this triage tool. And regarding the rapid diagnostic tests selection, you are the first ones to know that we do this. We never share this publicly. So we will see about the feedback in the future, in the near future. So this is the results for the community health screening network from the years from 2016 to December 2017. And this is the number of screening, the testing sessions in the first column, the number of people in the second column, the number of reactive cases in the third column from the 4 infections, and then the fourth column is the referral the cases that accepted referral to the NHS. So in blue, you see the percentage of reactive cases by 100 people. And in the red, you see the percentage of cases that were referred to the NHS, so linked by 100 people. So effective rapid screening programs are over 0.5 as you know. So we have 1.7 for HIV, 2.5 for hepatitis B, 2.8 for hepatitis C, and 3.7 for syphilis. So very effective screening programs. Okay.
There was another question from Lauren Combs from the European Testing Week Secretariat regarding the triage tool. How do you counsel persons who have been to your clinic before or are familiar with the screening process and do not want to answer all of the questions from the triage tool?
Then we do it the old way. We ask for the people regarding the reason for them coming to testing, and with that hint, we can see if it is a risk situation, and for each infections, and we go with that hint forward regarding the other 4 infections. So if people come for testing because they have, for instance, sexual partner diagnosed with HIV, then we apply the test for HIV and ask about the other exposures regarding transmission routes. And based on that, people can self-select to testing.
And would you be, again, a question from Lauren from the European Testing Week Secretariat, would you be able to give an estimate of the percentage of those screened that met the criteria for more than one infection?
I do not have that data with me. My colleague, my colleague Danielle Simões have that data regarding the percentage of people who are eligible for several testing in the same testing session. I do not have that data prepared with me.
Yes, thank you very much. But it's good for follow-up.
We have that data,
sessions.
but not here. Yeah.
Yes.
But as an example, since I have the data with me in my memory from checkpoints, HIV, syphilis, and hepatitis C infection, they are the most common testing session and goes up to 70% of our testing sessions.
Okay, that's quite impressive. So we had scheduled this this webinar for 45 minutes because we felt that sometimes we should give the opportunity also for shorter periods of time to be blocked. But so if no one else has any question, I would conclude this this call and thank you, Miguel, for participating and for sharing your experience. Yeah, and if that's okay, if you could send me your the version of your presentation that we could share with those who are interested and those who registered to the webinar.
Yes.
It was recorded, so I forgot to mention that at the beginning. So that will be available as well for those who couldn't attend. And you will also receive an evaluation form, which we would be very grateful if you could all fill in so that we can take lessons for future webinar to improve their relevance to all of you. So on that word, thank you again, Miguel.
Thank you.
And thank you everyone for joining and asking the questions. And there will probably be future webinars, and this is why, again, I would strongly encourage you to fill in the evaluation form. Thank you very much.
Thank you. Bye-bye.